Hello everyone, myself Prashant from Government College of Pharmacy, Bengaluru. In this video, I will be discussing about the topic evaluation of medication safety from the subject clinical research and pharmacovigilance. So before going to the topic, let's have a brief introduction about pharmacovigilance. We all know that pharmacovigilance is defined as the science and activities relating to detection, assessment, understanding and prevention of adverse effect or any other drug-related problems. And many other issues are also relevant to pharmacovigilance, such as substandard errors, spurious medicine, and medication errors. So, medication errors is one of the main reasons of adverse reaction or any drug effects which is caused, and hence there is a need for evaluation of that medication error. And medication errors may be either misuse, abuse, or overdose of a drug, as well as a drug exposure during pregnancy and lactation, are also important because they may result in an adverse drug reaction. Medicines improve quality of life by controlling disease but are associated with adverse reaction that may result in significant morbidity and mortality. If more than one medicine is prescribed, there is always a risk of drug interactions between them. And further, due to difference in genetic pattern, a patient may be respond differently to different medications, and they may develop different adverse effects. And the example is acute immunosis which is developed in patients with glucose 6-phosphate dehydrogenase deficiency and exposure to commonly prescribed anti-malaria drug Primaquine. The ultimate goal for this pharmacovigilance is to eradicate foster the rational and safe use of medicines and minimize the risk related to the drug use and maximize its benefit. So, according to the Institute of Medicine, it defines a medication error as any error occurring in the medication use process. Examples include wrong dosage prescribed, wrong dosage administered for a prescribed medication, or failure to give a medication either by healthcare provider or failure to take a medicine by a patient. And human factors inherently limit the safety of healthcare process and contribute to medication error. And there are many factors such as fatigue, inattention, memory lapse, or lack of knowledge of the particular medicine, and failure to communication between the healthcare provider and the patient, and interruptions while prescribing the dosage, and numerous other personal and environmental factors also play a role in medication error. Researchers have found that communication errors are the most common contributing factor in medication errors and adverse drug event. Communication issues noted in the study included both either it may be written type or verbal type. Examples of written communication problems included wrong dosages or wrong dose drugs on written prescriptions, or wrong medications noted on patient's medication list. And examples for verbal communication include misunderstood verbal physician orders, miscommunication between patients and the pharmacist, and miscommunication between nurses and the pharmacist regarding current medication or dosage. And before a drug is being marketed, it has to go through a series of tests which include animal tests, which is also called as preclinical testing, and various phases of clinical trials in humans to establish its safety and efficacy before it is being released to the market. And clinical trials being conducted in controlled conditions have various limitations. That is, it is being tested only in a small population, and it will be excluded in special populations such as children, old age people, and pregnant or lactating women. And the clinical trials consist of a restricted group of patients enrolled through stringent inclusion and exclusion criteria. Other factors causing adverse drug reactions such as genetic factors, environmental factors, and complete drug-drug interaction may not have been studied during these clinical trials. And data generated during clinical trials will provide information about the common adverse drug event, but not rare adverse event which will be seen during the post-marketing trials. And one example is fatal dyscrasia occurring in 1 in 5,000 patients treated with a new drug is only likely to be recognized after treating for more than 15,000 patients. And during the preclinical and clinical development of a drug, minimal safety information of the product is known to us, and continuous observation and evaluation is required under the real use of drugs in clinical practice and strong pharmacovigilance system is essential to monitor it. Several post-authorization safety studies are conducted either at the time of authorization or post-authorization phase for collecting data for the assessment of safety or efficacy of the medicinal product in clinical practice. So what are the evaluation which we can do at the pre-marketing safety studies? One, it is animal studies. In animal studies, we will be evaluating about acute and chronic toxicity, and this is conducting for weeks or 14 days or for more than a year in either one or two animal species. And we will be also conducting mutagenicity and carcinogenicity test. And it is a battery of tests which evaluates the potential for genetic problems. Testing is performed in at least two animal species for a period of 2 years. Testing is done only if the medicine is intended for chronic use. And another type of test which is conducted is teratogenicity, and this is conducted to assess ability to reproduce and have a normal offspring free of birth defects. The ability of the offspring to grow normally and reproduce is also tested extensively. And once after the preclinical studies, then we will go with clinical studies, that is with the human studies. And it is the study of the effects of medicine on humans under some controlled conditions. And the average number of patients used in this trial is approximately 4,000. And this trial is divided into four phases. One is phase 1, which is single dose studies and using low doses of the medicine. And another is phase 2, which is also called as efficacy and safety studies. Efficacy is the primary objective of phase 2 trials, but safety is also continuously monitored and evaluated. In phase 3, evaluation of safety in group of patients with the disease. Phase 3 trials may study the effects of medicine on, for example, the elderly or patients who have disease used for other medicines and have compromised renal and liver function. And phase 4 is also called as post-marketing surveillance. And the pre-marketing evaluations may have two drawbacks, and it may be either due to under-identification of the adverse drug reaction or over-identification of the adverse drug reaction. And under-identification, it may be due to low incidence of adverse effect, and those reactions with an incidence less than 1% are frequently not identified. Whereas in over-identification, many adverse drug reactions that are identified in preclinical studies are not proven to be casual, but are still listed in the product literature as potentially causing the adverse drug reaction. This practice provides a measure of legal protection for the pharmaceutical company, but is misleading to the practitioners because many of these reactions are not definitely proven. And once after the drug is proved to be safe, then it is been marketed. Even after the drug is marketed, it has to be evaluated for its safety, and this is known as post-marketing surveillance. After medicines have been released on the market, manufacturers are responsible for post-marketing surveillance of this product, identifying all the safety-related products that may exist with a new medicine is not possible during pre-marketing testing and evaluation, because pre-marketing testing is just only for predetermined period of time and only at the less number of patients or subjects. But under that prescribed condition, we cannot determine accurate drug adverse effect. Hence, post-marketing surveillance is also necessary. And the medicines released onto the open market will be used not only by more people but also by older and sick people and different ethnic groups, pregnant women and children, and will be prescribed in many different dose regimens. This circumstance inevitably lead to a potentially more adverse drug reactions. And post-marketing surveillance may lead to evaluating either by two types. One is spontaneous reports and another one is adverse drug reaction and adverse drug event. Spontaneous reports are the reports of an adverse drug reaction by a physician, pharmacist, or a patient. In many countries, these reports are sent to regulatory agencies or the manufacturer of the medicine. Spontaneous reports have been shown to identify new adverse drug reaction more often than any other method. These reports have the advantage of being available immediately as new products are released and throughout the market life of the medicine. The greatest limitation of spontaneous reports is that there is a significant underreporting of the adverse reactions, and another limitation is high incidence of a false positive in the reporting of the adverse events. One means sometimes the physician or pharmacist may think that this adverse reaction is not so accurate and it is not no necessary that it should be mentioned. It should be sent to the regulatory agencies. And sometimes there may be chance that they will be thinking that small effect also they will be sending for the adverse regulatory agencies. And hence because of this there will be under-reporting or over-reporting of the adverse effect. And prevention of adverse drug reaction and adverse drug event are many authorities agree that over 50% of adverse drug reaction may be preventable. And there is a general lack of knowledge concerning adverse drug reaction, including the incidence, severity, and impact on healthcare. Many adverse drug reactions are related to the prescribing of an incorrect dose and to administration of medicine to a patient with known allergy. And all these factors may not be in consideration while prescribing a medicine by the physician to the patient. Till now, I have discussed about various types of the medication errors and what are the types of medication error which may occur at the preclinical studies or either at clinical studies and post-marketing trials. And now I will discuss about the strategies for improving this medication safety and how to prevent these medication errors. A fundamental step in improving medication safety is for physicians and other healthcare providers is to be familiar with the medications that are available to treat their patients. First, they should know complete knowledge of that particular medication so that they could treat the patients and prevent the adverse effect better. And they can do this by maintaining up-to-date reference of current medications and have those references available at the time the drug is prescribed and understand the patient's conditions and diagnosis and indications for the medication considered, including all alternative therapies, and consider conditions that may affect the efficacy of the medication, such as dosage, route of administration, patient weight, renal and hepatic functioning, and other important patient characteristics such as pregnancy, age, etc. And understand the potential interactions between the newly prescribed medication and other medications already being used by the patient, including non-prescribed medications and supplements as well as therapies being considered, and recognize the potential risk of high alert medications, those drugs that bear a heightened risk of causing significant patient harm if there is an error in the medication use process. And intravenous oxytocin has been identified by the Institute for Safe Medication Practices as one such drug. And other strategies to improve medication safety include to ensure that a patient's current medication is continued, if appropriate, when admitting that patient to the hospital, and that additional medication used during the hospital stay is compatible with the patient's current therapeutic regimen, and to emphasize medication reconciliation during periods of care transition, including admission and discharge and subsequent follow-up in the ambulatory setting, and to provide relevant patient education about the reason the medication is needed and why it is prescribed, and pay attention to cultural or educational needs to ensure understanding and communicate the reasons for changes to a patient's medication regimen. And the essentials of safety rating medication orders include: one is focusing on certain elements of the order, and this order as follows. And medication order should be legible and should include the following components: name of the drug, dose, route of administration, and at what frequency the drug is to be taken, and reasons or conditions under which the drug should be administered if prescribing prorata. Prorata means under some certain circumstances, and patient's weight, age, etc. And writing an incomplete medication order substantially increases the risk of medication error, and the prescriber signature and identification number should be included in the prescription. And zeros and decimal points, the misusage of leading decimals and trailing zeros can be dangerous. And the adage leads always lead never follow can help mitigate errors which can lead to tenfold or hundredfold dosage errors. Example, always write 0.1 and never write 0.1 or 1.0, etc. And standardized abbreviation, the use of non-standardized abbreviation creates confusion and can attribute to medication error if the abbreviations are not interpreted as intended by the prescriber. And most healthcare institutions have standardized list of acceptable abbreviations. Verbal medication order should be limited to urgent situations in which written medications order are not feasible. And to ensure accuracy, verbal medication order should always be followed by a readback by the person who is receiving the order. The prescriber should ask the receiver to repeat the order to the prescriber if it is not been read back already. Because many drugs have names that sound alike, it is also helpful to include the indication for the drug in verbal medication orders. And another type of evaluating this medication safety is by using health information technology to improve medication safety. In 2009, the Health Information Technology for Economic and Clinical Health Act created an opportunity for professionals and hospitals to qualify for Medicare and Medicaid incentive payments if they implemented a certified electronic health record technology that met some specific objectives. As of 2011, healthcare providers and hospitals must demonstrate meaningful use of certified EHR, that is electronic health record, in order to receive this bonus payments. Among the many meaningful use core measures, several objectives are specific to medication management, and it includes the following. That is, maintain an active medication allergy list, maintain an active medication list, use computerized physician order entry for medication errors, and generate and transmit electronic prescriptions for non-controlled substances. Under computerized physician order entry, it refers to a computer-based system of ordering medications, laboratory tests, and diagnostic tests. Healthcare providers directly enter orders into a computer system that ensures standardized and legible and complete orders. To maximize its benefit, computerized physician order entry should include some levels of clinical decision support. A clinical decision support is an active knowledge system that uses two or more items of a patient data to generate case-specific advice. The system typically is designed to integrate a medical knowledge base, patient data, and an inference engine to generate case-specific advice. Electronic prescribing, also known as e-prescribing, it refers to a prescriber's ability to electronically send an accurate, error-free, and understandable prescription directly to a pharmacy from a point of care. Although electronic prescribing is a function usually found within computerized physician order entry system and embedded in many, if not all, electronic medical records, free-standing electronic prescribing systems also are available. These programs are internet accessible and can be used without existing office computer or virus system. Similar to computerized provider order entry, electronic prescriber can contribute to patient safety by reducing the chances that illegal prescriptions or improper dosage are accidentally written. And patient education and shared decision marketing making to enhance medication safety. This is to enhance the medication safety by improving the knowledge of the patient about the particular medicines. And regardless of whether non-automated or automated systems are used as part of the medication order process, patients need to be involved in the process as appropriate. And clinicians should confirm with the patient that she understands the medical condition for which a medication has been prescribed. For example, the teach bank method is useful for determining the retention and understanding of medication usage by asking the patient to repeat her understanding of the information back to a healthcare provider. And engaging the patient in her own care may improve adherence, outcome, and patient satisfaction, and also reduce opportunities for the error. And preventing an adverse drug reaction can be enhanced by evaluating the following before prescribing a medicine, and such as if this medicine the correct one for the patient's clinical condition, or the dose, route, and interval, the frequency, is it correct? And does the patient have any medical or physical condition that would affect the pharmacokinetic aspects? And does the patient have any allergy to this medication or a chemical similar to this medicine? Is the patient on another medicine that would cause an interaction? What is the patient's compliance with the medication? Is the medicine being prescribed is high risk of producing adverse drug reaction such as aminoglycosis, digoxin, warfarin, heparin, etc. Is the medicine being prescribed is of high quality? Is the medicine being administered correctly? And the following actions can help to limit the occurrence of adverse drug reaction. One is to review adverse drug reaction report regularly and inform the professional staff of the incidence and impact of adverse drug reaction in the region. And another is one is discuss changes in the formulary or standard treatment guidelines for significant or recurring problems with adverse drug reaction, and educate the staff, especially providers, concerning the adverse drug reaction, such as in-service education, face-to-face education with providers, medicinal information bulletins, and reports of collected adverse event. And identify medicines of the formulary that are high risk and should be monitored closely by physicians and pharmacists. For example, aminoglycosis, digoxin, heparin, they have high incidence of adverse drug events. And identify high risk patient population, including pregnant women, breastfeeding women, elderly children, and patients with renal or liver dysfunction. And close monitoring of this patient's population by physician and pharmacist will help prevent serious adverse reactions. And review medication error and product quality complaint to ensure that they are not contributing to the incidence of adverse drug reactions at the hospital. And prevention of medication errors are common. This medication errors are common event in hospital and primary care clinics. And medication error consists of administration of medicine or dose that differ from written order and includes medication prescribed, but it is not given to the patient, and administration of a medicine which is not being prescribed, and medicines will be given to the wrong patient, and wrong medicine or IV fluid administered, or wrong dose or wrong strength of the medicines being given, and wrong dosage form will be given, and medication given at the wrong duration or at the wrong time, and wrong preparation of the dose, and incorrect administration technique, and medication given to the patient with known allergy, and wrong route of administration being used, or wrong time or frequency of the administration. And there are many causes of medication error, but are generally attributed to following three factors. One is human factor, and workplace factor, or pharmaceutical factor. Under human factor, it may be either fatigue or heavy workload, and inexperience of lack of training, poor handwriting, and poorer orders of the pharmacist or the prescriber, or the one who is dispensing of medicines. And workplace factors such as poor lighting, noise, interruption, and excessive workload. And pharmaceutical factors such as excessive prescribing, confusing medicine and nomenclature, packaging or labeling, and increased number or quantity of the medicines per patient, and frequency and complexity of the calculations needed to prescribe or dispense or administer a medicine, and lack of effective policies and procedures, etc. And two broad interventions to reduce medication errors. One is to improve physician prescribing, and another one is to correct systems flaw that predispose to errors. Ideally, education programs for physicians can be developed with a focus on the most common prescribing errors. These errors, however, involve deficiencies in diverse areas, including knowledge of medicines, indications and doses, attention to renal and hepatic functions, awareness of medicine interaction, and willingness to routinely check allergy history. A more practical alternative has been to assign pharmacists to monitor medication order written by physicians. And specific interventions that are practical, at least in tertiary care hospitals, include the following things, such as establish a consensus group of physicians, pharmacists, and nurses to review current medicine prescribing and administration practices and the select best practices, and introduce a system to identify and record information about medication error. To encourage reporting, staff should not be fear punishment. The focus should be on system redesign. And where feasible, institute pharmacy-based administration of IV fluids. In what personnel must perform IV admixture, there should be clear written procedures and skill certification, and develop special procedures for high-risk drugs such as insulin, heparin, narcotics, theophylline, amyloglobulins. These procedures should include written guidelines, checklists, and education materials. And it requires handwriting by ordering physicians, pharmacists, and nurses should be instructed to call the prescriber rather than try to interpret illegible orders, and use a standardized designation for the doses such as milligrams, micrograms, or grams, and use the word units rather than u, and use the leading zeros for values less than 1, but not trailing zeros for the decimal. Example, write 0.2 mg or 2 mg instead of zero point 0.2 or 2.0 mg, and write the route of administration on all orders, and write out directions completely. Write daily instead of QD or QOD, and limit the use of oral or telephone orders to emergency situations that require that the order be read back to the prescribers. When preparing to administer a medication, confirm the identity of the patient by reading the patient's wristband and talking to the patient or family member. To minimize the likelihood that a dose will be missed, standardize administration times and develop a policy to provide doses when a patient is off the floor. And analyze medicine names as new products are added to the formulary. For look-alike and sound-alike names, establish a policy requiring that prescribers write both brand and generic name. And use pharmacy staff effectively to monitor and manage medicines use and distribution. So this was all about my topic called evaluation of medication safety. I hope you have understood all these things, and thank you.